cardiology is suited, but certainly it's a partnership. So thank you very much. I will share our setup. Asim had asked us to show some of our setup and some of our cases. I do have a disclosure. We have research support from Stryker. I will show the Triva device. I've also been on the DAWN trial data safety monitoring board, and there is a little bit of a misleading notion about DAWN and the 24 hours time window. We did, I was part of our first stroke case was in December of 2000, and I'm not saying it cannot happen, but in 18 years I've not seen a single stroke patient with a witnessed onset who was an endovascular candidate at 24 hours. Typically, they're either completed strokes or have good collaterals. So the 24-hour time window in DAWN, the bulk of the patients were those with unknown onsets or wake-up strokes. And those strokes, based on imaging, and if we could go back in time to see when they happened, probably happened just a few hours before they woke up. So just keep that in mind. With the DAWN, we now get patients with a witnessed onset 24 hours earlier, patient is transferred, but the infarct is completed. We talked about TPA. We looked at our own cost and data, and it is huge. It's the difference before and without TPA. Our costs are around $30,000 US. After, it's $40,000, $9,000 TPA injection. I'm not saying that TPA is not useful. It works in about 20% of the time, but the cost that we pay is not value pricing for the outcomes. And so at times we move away from giving TPA. We looked at our center and on how we can improve our outcomes. And for that, it's important, like Asim showed in the data sheet, it's important to measure time. It's so important to have quarterly audits. This is where our emergency room is located. These are our CAT scanners. These are our two neuro biplane suites, and the third one across the hallway. So this is the patient flow from the scanner to the angiography suite from the emergency room, which is similar to what we saw yesterday here at RIC. We have an EMS, emergency room, imaging, neuro, and then ICU. And we monitor times in all these locations. We employed one of the industrial engineers, Six Sigma, who trailed us and helped us in come up with a pathway where everyone's role is critically defined. And we see that in trauma. We see that in any exercise which requires a time-sensitive approach, so that at that time, at 2 in the morning, we are not second-guessing of what my role is or what the technologist's role is, what the nursing role is. Everyone does their own job independent of what another person may be doing. Similar algorithms exist, I'm sure, where Attila is, where Adnan is, where Umar is, Dr. Sabri. So they helped us even monitor how everyone stands in the room. We have a neurointerventionalist, 2 techs, anesthesiologist. The anesthesiologist is working on the arm. We're getting access, and everything happens. We try to make sure it happens simultaneously. This is a live case. We have cameras in the room in several places, at that time including a body camera. So this is a live stroke patient. You can see the attending, the techs are doing their work. This is during daytime, so maybe there are more people than normal. This is the anesthesiologist. And the prep happens fairly simultaneously. You can see this team here, the cabin. I'm sure you're familiar with that, with the STEMI work that you are familiar with. The report is called out from the emergency room nurse to the anesthesiologist, and then the case is started. We have a camera which is on the monitor, which is, this is the attending teaching the fellow. So sometimes it's difficult during the case to teach someone or what to do. So we save these, and it's like a debriefing after a case, or at least once a month. We also have a camera. This is on at that time on the interventionalist on the lead jacket. They're just showing access. We do 8 French access. The reported rate of access site complications on these trials was actually less than 2%. So a puncture is important, femoral head below the ligament. I second the comment made earlier about using ultrasound. There's no harm to do that to avoid access site complications. Almost all our patients get a closure device following the procedure, the 8 French axis. This is a live case, the onset at 10:30 in the morning, ER arrival 40 minutes later, CT scan, NIH stroke scale, no IVTP administered because of some pre-existing condition, aspects of 7. This patient had an M2 occlusion, so not a traditional LVO, but in this case, with this NIH stroke scale, and in our own data and publication experience, NIH stroke scale over 9 in an M2 occlusion is a useful marker for deciding on intervention. This is the CT angiogram, coronal view, which shows this is where the knowledge of, anatomy is important. This shows a right M2 occlusion. So it's important to know what is missing. Additionally, this patient had an aneurysm. I showed this case earlier in Lahore. There's a right MCA bifurcation aneurysm, left MCA bifurcation aneurysm. Other than that, the carotid is fairly straightforward. Perfusion imaging corresponds to a large inferior division deficit, which are typically functionally behave as a large vessel stroke. So this is our first attempt when we put the body camera. So I have a camera, we're recording our pathways. This is the hallway I showed you earlier. This is the CAT scanner. The neurology team is there. We're reviewing the CAT scan live, pointing out the right MCA bifurcation aneurysm, incidental contralateral left MCA bifurcation aneurysm. We plan on the treatment, and we have fellows, residents, et cetera. At the same time, while we're making the decision, the room has been alerted, and the prep has already started, obviously prior to the patient arrival. This is our setup I showed earlier. There's an anesthesiologist. 90 plus, or it's 80% of these cases are done with conscious sedation. Anesthesia, general endotracheal anesthesia is only used if there is compromise of airway or lay-by patient. And we'll go forward through some of the prep. So while the patient is being prepped, every tool, et cetera, is ready, and we puncture the groin while the anesthesiologist is still working. This is an 8 French access sheath, and the aortic arch, somewhat tortuous, a VTK catheter. And over that, you've seen earlier these, I will not go into the details because you've seen good examples earlier. We have an 8 French balloon guide catheter. You can see here the aneurysm, the superior division. We cross the neck of the aneurysm into the inferior division. So this is where it's important, as Adnan was mentioning earlier in the training aspects. It is critical to understand that there could be other challenges that are faced when doing a stroke intervention, such as a cerebral aneurysm that is right next to the occluded inferior division. And how to navigate across an aneurysm, and maybe what to do if, God forbid, something happens. So the microcatheter is positioned. It's a little bit proximal. We check the inferior division, which is pretty large. But the microcatheter position is a little bit proximal based on where the device will come. So after we do a gentle injection, the microcatheter is advanced little distally. And because this is a live case, there is some dead space which I am going to forward. We are inserting the stent retriever. And so here the stent retriever is coming up. This is a 4 millimeter by 20 or something Trevo ProView. And we bring it to the tip of the microcatheter. Now it's centered properly. Before it was proximal, which with a fairly gentle unsheathing, typically using the same hand with the other hand stabilizing the microcatheter at the hub of the guide catheter. Unsheath, you can see the distal tines coming out, so we have to be careful across the neck of the aneurysm, obviously. The device is now deployed. So again, we use one hand on the device and the delivery wire to manipulate it, and the other hand on the microcatheter hub. So this is an angiogram right after device deployment. You can see the clot is visible here with some stagnant flow proximal to that. The device is deployed well. We wait a couple minutes, as Attila pointed out, let the clot engage, inflate the balloon guide catheter, and start aspiration. We start vigorous aspiration fairly quickly because I think there is data that show there is flow reversal helps in the distal embolization to the same territory and also fragmentation to the new territory, the rate of which is about 8 to 9% of stroke cases may have distal fragmentation or involvement of a new territory. The device is absorbed, there is recanalization. Recanalization rate when I consent the patient is about 80, 90%, and I say we recanalize, the good outcome rate is about 70%. This is the post-operative MRI on day 2 with fairly good result. Obviously, we do have the more you do, you will have complication. As you've learned in cardiology, that when you do 100 cases, there's bound to be some bad outcomes, just the nature of what we're treating. Onset to ER in this case was 48 minutes, ER to CT 20, CT to puncture was a little bit longer. Puncture to recon 25 minutes, onset to recon was 2 hours, 20 minutes. I just show this out of interest. It's a 103-year-old. We don't normally treat that, but this patient lived independently at home, was functional. There are different criteria in octogenarians that are important that may not be that important in younger patients. Most importantly is mental, social health, family support, independent living. If someone is living in an assisted facility, neurocognitive deficit, they are not good candidates. But she lived independently. Again, this is during the day. Severe stroke, aspects was it, left IC a terminal occlusion. The non-contrast CT is fairly well preserved. No major area of early ischemic, and I can skip through the perfusion, but you can see there's a large left hemisphere deficit, preserved cerebral blood volume. Her clot is in the left internal carotid artery terminus, so fairly large clot. Look at the arch down here is a somewhat tortuous arch, heavy calcification, so we know going in that the access is going to be difficult in this patient. Let's skip that. This is the base angiogram confirming the IC terminal occlusion. This is the posterior communicating artery. This is the procedure. I'm showing the groin here because we've talked about it. There's a bad groin axis on the right side, so we went from first the left side, then punctured retrograde, and then antegrade in the right side. The procedure is accelerated a little bit. We used, in this case, a VTK catheter, fairly acute angle, but we can access into the internal carotid artery. There is a balloon guide catheter, confirms the occlusion. In this case, because of the size of the inclusion, we are using an intermediate catheter. Traditionally, we are more comfortable or have experience with stent retrievers from the Mercy days, so maybe we favor that, but now we do understand that there is no dogmatic approach to treating these, and we have to be open to use different devices, different techniques. There is prolapse while I'm pushing it up. Because the clot is hard, there is prolapse of the catheter into the aortic arch, so we inflate the balloon, secure the catheter, cross the middle cerebral artery, confirm we're intravascular in the inferior division. This is a 6 millimeter Trevo brought up, but you can see the deployment is not ideal. We should at least come into the native artery so we are centered over the clot. You can see the clot here as the device comes back. You can see the clot rolling across the stent retriever, so we probably lost the clot. We remove the microcatheter, aspirate it, do an injection, and there's still an occlusion. So no problem, go back, advance the intermediate catheter up into the face of the clot, remove it back and forth. We're aspirating. Now we have 3 aspiration systems, but manual aspiration, if you don't have a pump, is could be just as effective. Again, persistent occlusion, but you can see there are good collaterals coming back to the middle cerebral artery. This is the wire. We can see it's a firm clot because it's trying to kink. Get the wire across, reposition the microcatheter. Intermediate catheter is over here. Device is deployed. Asim, please tell me when it's time. So it's centered a little bit better, and you can see some recanalization through it. This time we remove the microcatheter, advance the intermediate catheter, aspirate through it, and pull the device, the intermediate catheter with vigorous aspiration. You can see a large thrombus, but the device is centered better than the first pass. And this is following removal. Can I show last case or no? Okay, so this is a simple aspiration only. Patient has a large ICA terminus clot. This is an 8 French infinity guide catheter, which is advanced all the way to the petrous segment, and aspiration is performed. And sometimes just aspirating through the neck can remove the clot. So we aspirate through that, remove the clot in the petrous segment, advance the wire, and then use the intermediate catheter aspiration alone to remove the clot. And these procedures, if it's just done with aspiration, can be fairly fast. Puncture to recanalization in this case was 9 minutes. I'll stop here in the interest of time. I think you've seen enough cases. This is one of the youngest patients I treated. She was 16 at that time in 2006. She's a nurse now. And the 103 fortunately went on to 105. We don't know where. So there can be rewards. There are obviously at times complications, but just a quick review of the live cases. Thank you.
Thank you very much, Dr. Ansaar. So in the interest of time, we will continue with our next talk. And our next speaker is, we are very delighted to have him here, is Dr. Osama Yassin Mansoor. He's president of MENA Sino and Stroke and Interventional Neurotherapies Organization, professor of neurology, Department of Neurology and Neurosurgery, Alexandria University School of Medicine in Egypt.
Thank you so much, Dr. Asim, for your kind invitation. And it's an honor and a pleasure to be with you. And thank you also for giving me the role of Mr. Bean, Mr. Complication. I will talk about the complication in my all talks. So I will start with the complication in endovascular treatment of acute ischemic stroke. I think the previous speaker has been clear very enough to show that the mechanical thrombectomy is the most effective and the most phenomenal treatment in the history of medicine. After the result of randomized control trial, we have a number needed to treat now of 2, so we need about 2 patients to have a good benefit for 1 patient. So please don't hinder any to let you any hinder factors to make you not giving the benefit for the patient by mechanical thrombectomy. I will talk about the 2 scenarios when we will work in the patient with acute ischemic stroke. Either we are satisfied with what we did in the angio with the patient, and either we are not satisfied. So we have 2 situations, either mission done or mission completed or mission held. So when we talk about the mission completed, we must keep in mind that the procedure should be with no complication, should be durable as regards the effect, and also should be have a positive effect on the final outcome. And we want to talk about what is the factor behind the mission hell. We should keep in mind the safety, the fast, the procedure, the cleanity of the procedure, the cleanity as regards self-hygiene, and also the environmental hygiene. This means that the embolization to the same territory or embolization to another territory, and the effectiveness of the procedure. And when we come to the mission completed, sometimes we have a situation after making our PEST to the patient and we have a fantastic result with full recanalization. In the next 48 hours, we had a situation with re-occlusion. And this re-occlusion has been presented in the literature. And there is some factors and predictor for this re-occlusion. Number one, the high platelet high platelet number of the patient at admission, and also the residual of the embolic fragments or the underlying stenosis. So please keep in mind if you have a patient with high platelet during the admission or having a residual of thrombus after mechanical thrombectomy or underlying intracranial stenosis, you should keep this patient closely monitored and frequently monitored. And the other one regarding the mission completed is an wanted outcome. Sometimes we did very fantastic job for the patient and then we have a bad outcome due to some thing that has gone wrong for the patient. And we have some data from the literature about this one, especially regarding the clinical outcome and regarding the occurrence of symptomatic intracranial hemorrhage and also as regarding the mortality. And the most important predictor for those are the admission NIH score. If it is high, so the patient will most possibly to have a bad outcome regarding those three factors, and also the sex and the presence of diabetes or increased blood sugar level, and also the reperfusion rate. The higher the reperfusion rate, the safer you will be away from this unwanted complication. Then we come to the what is hindering our job in the CAS lab and what is behind our unsatisfactory result in the CAS lab. I think first we need to define what is the fantastic or the optimum situation. The optimum situation is to have a TK3 from the first pass. However, this is not the reality in most of the condition, and the TK3 in the first pass is only achieved in about 10 to 15% of the cases, and this number can be reduced dramatically in complicated occlusion like tandem occlusion or underlying intracranial atherosclerosis. And this is why we should keep in mind that in this situation we should be more acrobatic, trying to recanalize the vessel in a shorter time. This is data coming from the literature showing that the higher the complexity of the procedure, the less the achievement of the TK3. And so we can divide our need into 5 items. We need safety, so we need to be safe as regards the procedure, and we need to be faster, so we should keep our procedure time shorter, and also we need to be clean as regards the ipsilateral territory of the mechanical thrombectomy procedure, and also clean as regards other territory of the vessel surrounding the acting or working vessel. And also we need to be very effective or near to the optimum situation, which is achieving TK3 in the first pass effect. So let's start with safety. And when we talk about safety, two problems come in mind: the occurrence of symptomatic intracranial hemorrhage and the mortality. And regarding the symptomatic intracranial hemorrhage, we in the literature, the range is between 2 to 5, and this range is slightly higher, but not significantly higher when compared the endovascular procedure with intravenous thrombolysis. And when we need to be more safe, we should keep our this number below 2%. And regarding the mortality, I think this is the current range in the literature is between 20 to 25%. And when we have an optimum, we need to be to have an optimum situation. We need to decrease this number into below 15%. And this number is higher in the intravenous thrombolysis when compared to endovascular technique for recanalizing the vessel. And this number is more and more decreasing when using the new techniques. And this is can be extrapolated from showing the difference result from sequential randomized control trial. And also the procedure is somewhat not clean because it is traumatic. The stent retrieval is traumatic, and this has been published in some literature showing that by just making a fantastic job, the post-interventional CT can show subarachnoid hemorrhage in 5.5% of cases. Not all of them are symptomatic, of course, but the presence of subarachnoid space in post-interventional procedure is a predictor for conversion into symptomatic intracranial hemorrhage in the next 24 hours. And the most important factor to have such situation is the number of passes. So the higher the number of passes, you will be more close to the complication. And this is a very interesting case from our data showing that the mechanical thrombectomy is going without no complication. This patient it's 61 years old, and she presented after trauma and with NIH score 23, and she had the native CT showing the hyperdense sign in the middle cerebral artery, and this is the first angio showing occlusion in the right internal carotid artery. And so we tried to make the task with mechanical thrombectomy. This is the first pass, and this is the second pass, this is the third pass, and this is the fourth pass, and this is the final results. And after fifth pass, we have some infarction, but the most important is that the patient have decreased the NIH score to a non-convenient number after the procedure, and this is the result after the procedure. The patient have progressive symptoms of carotid cavernous fistula. This is the CT showing the fistula, and so we decided to take the patient to the angio suite and do a coiling for the vessel. And this is the end result. But however, this is the patient after the coiling, and still patient have non-convenient outcome. So the procedure is not innocent. The procedure is invasive or minimally invasive, and should we keep that in mind? This is another case with M1 occlusion. We tried to make the task with balloon guided catheter, and this is the stent retrieval. And when look at the wire of the stent retrieval, the radio-opaque wire, and when we tried to retrieve the stent retrieval, we realized that the wire is not there. So we realized that the stent has been detached, and so we tried to get the stent retrieval by snare, and actually we succeeded to retrieve the stent retrieval. This is the result. This is the final result. And this is the post-mechanical thrombectomy MRA showing, of course, some hemorrhagic transformation. So it's not clean. And also when we talk about shorter procedural time, be fast, please, because it is a predictor to have good outcome. It is a predictor to shorten your procedural time. And from the literature, we have accepted procedural time between 40 to 60 minutes, and of course we need to decrease all workflow starting the pre-hospital to the intra-hospital workflow, and especially the mechanical thrombectomy procedural time should be decreased. And we have that from the literature, from the TREVO registry, SWIFT trial, and ACE trial, showing that the time should be decreased below 40. And this is a probability curve showing when you have a longer time of the procedure, you will be in a situation to have more complication. So please keep your procedure short. And when we talk about the clinicity and regarding the distal embolization, it's very important to keep in mind that from the IMS3, we know that the embolization to distal territory is about 15%. It's a high number. And also this is a significant association, significant association with occurrence of bad outcome post-procedural. And also, there is absolute difference of about 13% between those patients having distal embolization and those have not distal embolization. And there is some tricks about preventing such the distal embolization. Please try to use a balloon guiding catheter or try to use suction from distal large bore catheter. And we have this evidence from literature. This has been published recently about the experience of using a balloon guiding catheter of decreasing the number of distal embolization and also of achieving a good outcome. And so very interestingly, when you have this situation, the patient having a first spastic effect to recanalize the vessel, most of the cases, you will be sure that this patient will do well after the procedure. This is a patient, 90 years old, known to be hypertensive diabetic, and the patient have a woke-up stroke, and this woke-up stroke weighted by NIH score into 11, and the patient have a CT showing that aspect score about 7, and CT angio showed left internal carotid artery occlusion. So we decided to go for this patient by mechanical thrombectomy, and this is the angio of the patient, EP and lateral, showing from the other side, showing that the collaterals is coming to reconstitute the occluded vessel. And this is the injection from affected side, showing occlusion in the internal carotid artery. This is the EP and lateral view. So we tried to recanalize the vessel by starting by the aspiration, and then we use the stent retrieval. And we realized that there is a carotid terminus occlusion. This is the thrombus. And we achieved this outcome by stent retrieval. But please look at the lateral view. Did you see any abnormality here? This one. Okay, it's fantastic. So, yes, this is similarly what happened for me during the cath lab when I find these findings. I realized that there is an occlusion in the posterior circulation. This is a BCOM showing a thrombus there. So when we tried to recanalize the anterior circulation, we was not clean to have distal embolization to another territory. So we decided to go to the other side. This is the occlusion. And we achieved the procedure. This is the occlusion from the posterior circulation. And we achieved recanalization by stent retrieval. And we recanalized the vessel, yes. Thanks God that the patient woke up in a fine condition. And so this is, sorry. This is, it is not working. Yes. This is a final post-procedural MRI showing there is some embolization in the posterior circulation after the occlusion of the BCE. So we are also, this is another case showing that we could be more harmful for the same ipsilateral territory. This is middle cerebral artery occlusion at the left side, and this is the diffusion, initial diffusion, and the perfusion, and this is the angio. This is after recanalization, and this is the post-procedural diffusion, showing that we have some embolization in another territory which are not present, were not present before the procedure. So we will finish with this part. We should be in situation as near as to the optimum. We need to be fast and also to achieve for recanalization from single pass. And this is, has been extrapolated from the literature. This is a situation which is optimum when you have something like that and you have the first pass effect like that. Most of the cases you will have a favorable outcome. And when you have another situation, this is another patient, and you have 7 passes, and they have the final result, actually the situation will be unfavorable outcome. This is the result from the NASA Solitaire registry, showing the first pass is very effective in having a good outcome. So time, the problem is, sometimes the problem is a human factor by itself, like in this case. This is a basilar occlusion. Yes, just 1 minute. And we tried to recanalize the vessel by double stent retrieval technique. This is a 2 stent retrieval, one in the PCA in the right and the other in the left. And we achieved this result. But the patient, during the angio, we realized that the patient have a stenosis in the middle cerebral artery on the right side. So we kept the patient on double antiplatelets. And we realized after that the patient have retroperitoneal hematoma. And so we took the patient to the angio suite, and we performed a grafted stent for the right external iliac. However, the patient after a while, the hemoglobin decreased dramatically, and the intra-abdominal pressure increased dramatically, and we informed from the ICU specialist that the patient have abdominal compartmental syndrome. This is a very bad situation, and we should stop the treatment antiplatelets and do decompression for the abdomen. So we stopped the antiplatelets for 4 days, and the 4th day, the patient developed another neurological deficit, and this is the MRI. So we realized that the patient have occlusion in the internal carotid artery, which harboring the MCA stenosis. So we decided to go to recanalize the vessel, and this is the result. But the patient is not doing well. So also, sometimes the complication is human factor, and we need to be very well trained. And my message is when I will be a patient, please, I'm not care about the specialty of the doctor who is treating me. The most important is to be effective and safe and away from complication. Thank you.